us from around the world. It's great to see so many people logging in and saying hi on the chat. We are so pleased that you could join us for today's presentation with Professor Mary Marcondes. Before I introduce Mary Marcondes, there are a few things that we need to go through. The first is that we have live interpretation available for today's webinar. If you have a look on your Zoom menu, you should see an option. On my menu, I can see I have to click more, and then there's an option for interpretation. We have live translators in Turkish, Spanish, and Portuguese. So if you would prefer today's presentation in Turkish, Spanish, or Portuguese, that is available for you with live interpretation. So you can go ahead and switch over to that. The second thing that we would like to highlight is that we will be having a live question and answer session at the end of today's presentation with Professor Mary Marcondes. If you have a question that you would like her to answer, please ensure that you put that question into the Q&A section in Zoom. Again, if you look in your menu, you should see an option for Q&A. If you click onto that and add your question into that, then it will be recorded and we can make sure to present it to Professor Marcondes. We will be going through a couple of questions at the end of today's session. If we don't have time to get to your question that you put into that section, don't worry. It will be recorded and presented to Professor Marcondes, who will provide an answer. All of the questions and answers will be sent along with the recording of today's session to you at a later date. But please make sure that you put it into that Q&A box and not into the chat because it will be properly recorded in the Q&A box, and sometimes they can be missed if they are in the chat. Today's presentation by Professor Marcondes will address the new classification of core vaccines according to the 2024 WSAVA Guidelines, the different types of vaccines and consequent immune responses, the reasoning behind the use of multiple doses of vaccines in the primary vaccinations of puppies and kittens, and the revaccination protocols based on the duration of immunity and use of serological tests to assist in decision-making. My name is Jessica Case. I am the manager of Complete Veterinary Care. We are the Biogal distributors here in the UK. If we have any UK joining in, any vets or nurses or veterinary professionals from the UK joining in, and you would like any more information about the Biogal products, then please do get in touch with us at info@cvcgroup.co.uk, and we'd love to hear from you. For all others that are joining in, if you would like information about the Biogal products, you can have a look on their website at www.biogal.com, and you can email them at info@biogal.com. Before I introduce Professor Marcondes, one more reminder that there is live translation for Turkish, Spanish, and Portuguese. Just click your interpretation button in your Zoom menu. And so please ensure that you put all questions into the Q&A section. So again, on your Zoom menu, you will see a Q&A box. Please make sure that you put your questions in there and not in the chat so that we can make sure to record them and present them to Professor Marcondes. Professor Mary Marcondes qualified as a veterinary surgery from the University of Sao Paulo and completed a residency in small animal internal medicine and surgery at the same university. She holds an MSc in clinical veterinary science from Sao Paulo State University and a PhD in clinical veterinary science from the University of Sao Paulo. Professor Marcondes held a postdoctoral position in infectious diseases at the Department of Pathology, University of Sao Paulo Medical School, and at Dr. Janet Foley's Laboratory in Infectious Disease, University of California. She worked at Sao Paulo State University from 1992 to 2018, from where she retired as an associate professor of small animal internal medicine and infectious diseases. Her research focuses on companion animal infectious diseases. Currently, she serves as the chair of the WSAVA Vaccination Committee and is a member of the African Small Companion Animal Network Project Board. Thank you so much for being with us today, Professor Marcondes. With this, I will hand over to you for today's presentation.
Hello, everyone. First of all, I would like to thank Biogal for the invitation to talk about the 2024 WSAVA guidelines for the vaccination of dogs and cats and serology testing. And thank you for the introduction. Let me start by explaining why we have vaccination guidelines. Over the past 30 years or so, concerns have been raised over the safety of repeated administration of vaccines in both human and veterinary medicines. In response to these discussions, the veterinary profession has formed expert groups that have provided guidelines promoting a different approach to vaccination. These guidelines consider how vaccination of companion animals might be carried out more safely, while still ensuring the protection of individual animals and maintaining herd immunity against vaccine-preventable infectious diseases. It is important to consider the definition and scope of vaccination guidelines. Guidelines are non-compulsory recommendations that help practitioners use vaccines efficiently. They are based on current scientific thinking and expert opinion. These guidelines strongly encourage veterinarians to move away from the one-size-fits-all vaccination policy and instead consider the infectious diseases risks specific to their local area or country, adapting vaccination needs to each individual animal. In veterinary medicine 20 years ago, and still in some countries, especially in Latin America, the vaccination of adult dogs and cats was perceived to be a relatively straightforward process, where every animal enrolled with a practice received all vaccine components every single year. To minimize the unnecessary administration of vaccine antigens to dogs and cats, vaccines can be categorized as non-core, core, and not recommended. In the 2024 guidelines, the VGG slightly adjusted the definition of core vaccines to enhance clarity. This resulted in the recategorization of some vaccines. The VGG now defines core vaccines as those that all dogs and cats should receive, taking into account the geographic areas in which they live or visit. Some core vaccines protect animals from diseases with global distribution, while others protect against diseases prevalent only in specific countries or regions. Non-core vaccines should be recommended for animals whose geographic location and lifestyle puts them at risk of contracting specific infections. The practitioner will decide which non-core vaccine each patient should receive based on a careful conversation with the owner. A patient-specific vaccination plan should consider environmental risk factors, life stage, and lifestyle that influence the likelihood of infectious disease exposure and susceptibility. We strongly encourage practitioners to educate their clients about the importance of regular health checks, rather than speaking of vaccination consultations. The annual health check is much more than just a vaccination consultation, although it often includes the administration of selected vaccines that need to be given annually. The VGG has classified some vaccines as not recommended, where there is insufficient scientific evidence to justify their use. So, core vaccines for dogs in all parts of the world are those that protect against canine distemper virus, canine adenovirus and canine parvovirus. I will focus on those vaccines in my presentation. In regions where rabies is prevalent, vaccination against rabies should be considered core for dogs and cats. Leptospirosis in dogs is another zoonotic disease widely distributed around the world. Previously, vaccines for lepto in dogs were classified as non-core in our guidelines. However, in our latest guidelines, we strongly recommend that in countries or regions where the disease is present, vaccination of all dogs is highly recommended, and these vaccines should be considered core. Core vaccines for cats in all parts of the world are those that protect against feline parvovirus, feline herpes virus, and feline calicivirus. I will focus on them. In regions where rabies is endemic, vaccination against rabies should be considered core for cats. And in the 2024 guidelines, the VGG has designated FEOV vaccines as core in areas where the disease is prevalent. In these regions, FEOV vaccines should be considered core to all cats under 1 year of age and for older cats without outdoor access and those living with other cats that have outdoor access. The decision to use FEOV vaccines in cats older than 1 year should be based on their lifestyle and risk of exposure. Before we talk about protocols, let's clarify the difference between modified live and inactivated vaccines. Modified live vaccines contain a live but attenuated whole organism capable of infecting cells and replicating within them. This establishes a low level and transient infection, mimicking a natural infection without causing disease. Due to this property, they are generally more immunogenic and usually require fewer doses to immunize. They usually generate a robust immune response, lasting for many years, if not for life, after a single dose without the need for revaccination. However, there are exceptions to these, and we are going to discuss them further during this presentation. As examples, we have modified live vaccines against canine adenovirus, canine distemper virus, and canine and feline parvovirus. Inactivated or killed vaccines containing titer inactivated microorganisms that are not able to infect or replicate, but can stimulate an immune response. As they do not mimic a natural infection, they usually produce less potent immune responses and generally require multiple doses and sometimes an adjuvant to stimulate an adequate immune response. Most inactivated vaccines are thought to require at least 2 initial doses to immunize, regardless of the animal's age. The first dose generally primes the immune response, and the second dose provides the protective immune response. Inactivated vaccines usually provide a shorter duration of immunity when compared to modified live virus vaccines, and more frequent revaccination is needed to maintain immunologic protection and memory. Examples of killed vaccines include those for lepto, some Bordetella bronchiseptica vaccines, rabies, and rabies vaccine is an exception since it is highly immunogenic and can induce protective immunity with a single dose. Let's talk about the concept of maternally derived antibodies interference. Imagine this is a graphic of an immune response to a specific disease, and 80 represents the minimum antibody level required to protect the dog against the disease, while 20 is the minimum antibody level that interferes with the vaccination. This means that while the neonate has an antibody level above 20 for this disease, he will not develop an immunological response when vaccinated. In most puppies and kittens, maternally derived antibodies decline to a level where it is possible to elicit a response to vaccination in about 8 to 12 weeks. However, some animals may still have maternal antibodies above this level around 14 to 16 weeks of age. And that's what's happening in this graphic. The amount of MDA cannot be predicted because it varies depending on the titer of the dam or queen and the amount of colostrum ingested after birth. So in this graphic, the animal will be protected by MDA until around 11 weeks of age. During the period when MDA are insufficient to provide complete immunologic protection, but still enough to block the endogenous immune response, known as the window of susceptibility, the animal can become infected if it comes into contact with a pathogen. It is not possible to predict when this window occurs, as the amount of MDA transferred will vary between litters and within litters for individual neonates. After MDA drops below the interfering level, the animal is responsive to vaccination. As it is not possible to predict the exact moment of loss of MDA, the initial core vaccination series with modified live virus vaccines usually requires the administration of multiple doses. These are not booster doses. They are applied to trigger a primary immune response as soon as possible after the MDA has dropped. So in this situation here, the vaccine applied at 6 weeks does not elicit an immune response. The same at 10 weeks. But now at 14 weeks, MDA is below the minimum antibody level that can block an immune response, so the animal starts to produce antibodies. In this other situation, MDA stays above the interfering level until 16 weeks. So vaccines given at 6, 10, and 14 weeks are not able to elicit an immune response. But a vaccine given at 16 weeks will elicit an immune response. So the most important dose is that administered at 16 weeks of age or older, when almost all puppies and kittens must have already lost MDA, being able to respond to the vaccine. Again, we are giving many vaccines not as boosters. However, when we talk about feline herpes and calicivirus, even when we are using modified live virus vaccines, we must give 2 doses. This is because calici and herpes virus vaccines are thought not to provide such potent, long-lasting protection as panleukopenia vaccines. For these agents, the first dose generally primes the immune response, and the second dose, usually administered 2 to 4 weeks apart, provides the protective immune response. Usually, maternal antibodies against herpes and calicivirus vanish before antibodies against panleukopenia. So usually kittens will be able to respond to vaccination for calici and herpes virus earlier than for panleukopenia. So again, multiple doses of vaccines against distemper, parvo, adenovirus, and panleukopenia are not boosters. We are trying to elicit an immune response as soon as possible. In the absence of MDA, a single dose of core-modified live vaccine against distemper, parvo, adenovirus, or panleukopenia provides adequate and robust immunity. What we recommend in our guidelines is, as an example, if a puppy or kitten starts the core vaccination at 6 weeks with a 4-week interval, has a second dose at 10 weeks and a third dose at 14 weeks, we need to revaccinate again at 16 weeks or more. In this other situation, starting at 8 weeks of age, we can give a second dose at 12 weeks and a third dose at 16 weeks. So the number of doses of core vaccines in puppies and kittens will be determined by the age at which vaccination is started and the selected interval between vaccinations. In the past, it was recommended that revaccination be performed 1 year after the initial series. However, owing to studies that suggest that some puppies may still have MDA at 16 weeks, and up to 1/3 of kittens may fail to respond to a final core vaccine at 16 weeks, and may have blocking MDA at 20 weeks, the VGG recommends that the 1-year vaccine be replaced with revaccination at 26 weeks of age, which is around 6 months. The purpose of this vaccine is not to boost the immune response, but to ensure the development of a protective immune response in any puppy or kitten that may not have responded to the primary core vaccines at 16 weeks. With the previous protocol, a puppy or a kitten that fails to respond to any of the core primary vaccinations would be left unprotected until receiving another vaccine at 12 months of age. For parvo, distemper, and adenovirus, we recommend an initial vaccine at 6 to 8 weeks of age, then every 2 to 4 weeks, until 16 weeks of age or older, with a subsequent dose given at 26 weeks. This 2-week interval should be carried out in environments likely to be heavily contaminated, such as shelters. After the last dose at 26 weeks, we can revaccinate every 3 years. And if the dog is older than 26 weeks, only 1 dose of modified live core vaccines is enough to immunize, because we don't have MDA anymore. Some practitioners are more concerned and prefer to give 2 doses, afraid that the first dose may not have immunized. It's not a problem. But the important thing is to remember that it is not necessary to give multiple doses, because there are no longer maternal antibodies at this age. Many studies have shown that dogs vaccinated with modified live core vaccines are protected for quite long periods of time. In this review, Dr. Ron Schultz highlights that for distemper, depending on the strain used in the vaccines, immunity could last between 9 and 15 years. For adenovirus and parvovirus, immunity could last 9 years. In this article, the author showed that in dogs kept in natural environment, protective antibodies were found to persist for 14 years for distemper, 14 years for adenovirus, and 10 years for parvovirus. Dogs could not be kept in environments free for viruses for more than 9 years, but they were all protected during this period. This was a study performed in Australia that involved almost 250 dogs. These dogs here were last vaccinated anytime previously, between 1.5 years to 9 years. And more than 96.6% of them were considered protected against parvo, distemper, and adenovirus. For feline panleukopenia virus, herpes virus, and calicivirus, we recommend an initial vaccine between 6 and 8 weeks of age, and then every 2 to 4 weeks until 16 weeks or older, with a subsequent dose given at 26 weeks. So it's the same that we do for dogs. This 2-week interval should be carried out in environments likely to be heavily contaminated, such as shelters, as we said for dogs also. When I was talking about modified live vaccines, I said that although most of them promote a robust immune response with a single dose, there were exceptions. So while the panleukopenia vaccine provides strong and long-lasting protection, the protection given by calici and herpes virus vaccines is partial and does not protect against infection or the development of a carrier state. And we usually recommend 2 doses of calici and herpes virus vaccines, even when we are using modified live virus vaccines. And they need more frequent revaccination, especially if they are cats at high risk of getting infected. So if the cat is 26 weeks or older, a single dose of modified live virus panleukopenia vaccine would be sufficient to immunize, but we recommend 2 doses for herpes and calicivirus. And if we are using an inactivated vaccine, we must always give 2 doses. The VGG recommendation for adult low-risk cats, defined as solitary indoor cats that do not visit boarding catteries, is to revaccinate every 3 years. However, high-risk cats should be revaccinated every year against calici and herpes virus, such as outdoor cats and cats that regularly visit boarding catteries or have contact with potentially infected cats. Some countries have bivalent vaccines containing calici and herpes virus. These vaccines enable practitioners to vaccinate high-risk cats against calici and herpes virus annually and against panleukopenia every 3 years. In this study, 112 cats, adult cats, were vaccinated with 1 dose of modified live virus vaccine against panleukopenia, and antibody titers were determined before vaccination, 7 and 28 days after. An adequate response to vaccination was defined as a 4-fold titer increase. This means that this cat presented an amnestic response by memory cells. Pre-vaccination antibody titers greater than or equal 40 were present in 64% of the cats. Only 47% of the cats had a 4-fold titer increase, indicating an adequate response to vaccination. None of the cats with high pre-vaccination antibody titers had a 4-fold increase. And what does this mean? This suggests that cats with high antibodies probably neutralize the vaccine virus before it can stimulate the immune system, similar to what occurs in kittens with maternally derived antibodies. Based on these findings, the authors recommend that instead of simply revaccinating cats against panleukopenia, the idea is to evaluate their titers before deciding if they need to be revaccinated. Additionally, the study revealed that 4% of the cats were non-responders, and we will discuss this further shortly. However, it's worth noting that the only way to identify a non-responder dog or cat is through serology. So, how can I know that my patient is protected? There's a strong association between the presence of antibodies and protection against many infectious agents. So we can measure antibodies to determine if the animal is protected. This correlation is very strong for canine distemper, parvovirus, adenovirus, and feline parvovirus. So much so that we can say that if an animal has antibodies, it is protected. However, it is important to note that the absence of detectable antibodies doesn't necessarily indicate susceptibility to infection and disease. An animal that has been properly vaccinated and does not have antibodies against these diseases is probably protected by memory cells. But since we cannot measure memory cells, the absence of antibodies has generally been used as a clinical indication for revaccination. Although panleukopenia has a very strong association between the presence of antibodies and protection, for herpes and calicivirus, protection is not correlated with circulating antibodies, but with mucosal and cell-mediated immunity. Protection against calicivirus has been shown to correlate to humoral virus neutralizing antibodies, cellular-mediated immunity, and mucosal IgA. However, because of feline calicivirus strain variation in the field, the value of antibody testing in predicting protection is limited. Neutralizing antibody titers detected against laboratory strains of feline calicivirus might not correlate with protection against field strains due to the absence or insufficient cross-neutralization. Not too long ago, determining whether a dog or a cat had protective antibodies involved obtaining a blood sample and sending it to a laboratory for gold standard tests. These tests include the virus neutralization test, commonly used to detect antibodies against distemper and adenovirus in dogs, and the hemagglutination inhibition for antibodies against canine and feline parvovirus. However, with the new technology, point-of-care tests are now available for use in veterinary practices. It's crucial to select tests that have been validated by independent scientific publications to ensure their accuracy and reliability. These rapid tests have the advantages of being simple to run and quick. You can have your results in 20 to 30 minutes. They are not that expensive, but unfortunately, they are still more expensive than giving a vaccine. These tests are available for distemper, adenovirus, parvovirus, both canine and feline parvovirus. Although some tests can also detect feline calicivirus and feline herpes virus antibodies, as we have discussed, the stronger correlation of protection for calicin herpes virus is with cell-mediated immune responses. So these tests are validated against the gold standards for each pathogen, and they must have high specificity and high positive predictive value. And why this is so important? The biggest concern regarding in-practice serological testing lies in the specificity of these tests. When using tests to measure antibodies and determine if a dog or cat is protected, high specificity is essential. For example, if a point-of-care test has a specificity of 80%, it means that 20% of the results could be false positives. A false positive result would suggest that an animal has antibodies and is protected. But in fact, because the result is falsely positive, the animal doesn't have antibodies and should be revaccinated. So we need to be careful when choosing a rapid test, and even when we use gold standard tests. Universal laboratory reference standards for protective antibody titers have not been established. Different commercial laboratories may report different results when evaluating the same sample. The positive predictive value tells us how many of the positive results are true positives. and it is related to the prevalence of the disease in the population. So when selecting a point-of-care test to use in practice, veterinarians should choose tests with independent scientific publications validating their sensitivity, specificity, and predictive values relative to gold standard tests. Recently, the comparison of several point-of-care tests with gold standard testing in Germany revealed variations in performance relative to the gold standard tests. A concern highlighted by these publications is that these tests were not reliable when used to test dogs with acute illness or healthy-looking dogs with chronic disease, particularly for canine distemper virus and canine adenovirus. We are not concerned about dogs with acute illness because we won't vaccinate them anyway. But the reliability of these tests in detecting antibodies in chronically ill dogs raises important questions. Those were the first studies that evaluated point-of-care tests in dogs with chronic diseases, so further research is needed to understand if there are limitations of point-of-care tests in these situations. This study evaluated the agreement between the VacciCheck test and the virus neutralization method. A total of 106 canine sera were examined using both techniques. Virus neutralization was considered protective when antibody titer resulted in equal or more than 60. The VacciCheck test employs a semi-quantitative ELISA method, where the concentration of antibodies is determined by the intensity of coloration of spots on a scale from 1 to 6. An S3 value indicates a significant positive response according to the manufacturer. When considering a significant positive response for VacciCheck and a titer of 16 for the gold standard, the specificity was 93.5%. When they considered the positivity threshold of 32 for the virus neutralization, the specificity for the VacciCheck was 87.2%. In this other study, they tested 431 pet dogs and 132 samples from specific pathogen-free beagles. Results of the VacciCheck were compared to the gold standards, and specificity was 87.5 for distemper, 90% for adenovirus, and 94% for parvovirus. This study tested 347 cats that were presented to a university hospital in Germany for the presence of antibodies against panleukopenia. Samples were tested by the gold standard with 3 different cutoff points and by VacciCheck. We can see here that the specificity varied from 81 to 89%, with the best result when the gold standard cutoff was considered 20. The positive predictive value varied from 89 to 96%. So, when will you consider using serology? The first situation is how to know if a puppy or a kitten in early life has actually responded to the core vaccines, and to help identifying animals that may be genetic non-responders. If I gave this puppy a vaccine at 6, 10, 14, and 16 weeks of age, how do I know that it is protected? We can perform a titer test 4 weeks after the last vaccine dose. In this case, at 20 weeks of age, we will test to see if the puppy has antibodies against distemper, parvo, and adenovirus. At 20 weeks old, it would be highly unlikely that this pup still has maternal antibodies. So if this puppy is protected against the 3 antigens, you don't need to give the last vaccine at 26 weeks of age because it's not a booster, remember? And you can start revaccinating every 3 years. If a puppy is seronegative for 1 or more antigens, the recommendation is to revaccinate and then wait 4 weeks before repeating serology. While some may consider switching brands of vaccines, it's important to note that for core vaccines, there's generally little variation between manufacturers. Therefore, changing brands may not significantly impact the vaccination outcome, but this is an option. You can change the brand to see if now this puppy is going to respond. If the puppy is now seropositive, you can revaccinate every 3 years. If for some reason this puppy remains negative after revaccination, and usually it happens for one component, such as distemper or parvovirus, this puppy may belong to a small group of animals known as low or non-responders. These animals lack the necessary immunological machinery to mount a protective immune response to specific antigens. They may lack the appropriate molecules needed to respond to a parvo or to a distemper vaccine, for instance. No matter how many times you vaccinate them, these animals will not develop the necessary protective immunity. Some of these animals may still have some level of cell-mediated protection, but others may truly lack any protection at all. And if you want to test a cat, as I told you before, some studies have shown that a small number of cats may still have maternal antibodies at 20 weeks of age. So I recommend testing a cat at 22 weeks or older. At 22 weeks, it would be highly unlikely that this kitten still has maternal antibodies. If a kitten is confirmed to be protected against feline panleukopenia, it is not necessary to administer the last vaccine at 26 weeks of age. Instead, revaccination against panleukopenia can be done every 3 years thereafter. However, we need to remember that vaccination against calicin herpes virus may be needed annually. If the kitten is seronegative, you will have to revaccinate it and retest in 4 weeks. If the kitten is now seropositive, you can revaccinate every 3 years for panleukopenia. However, if the kitten is still negative, then it may be a non-responder. The immune response, being a biological process, never confers absolute protection and is never equal in all members of a vaccinated population. The range of immune responses in a large random population of animals follows a normal distribution. This means that most animals respond to vaccines by mounting an adequate immune response, whereas a few will mount an excellent response and a few will mount a poor immune response or will not respond at all. These poor responders may not be protected against infection despite having received an effective vaccine. So here's another situation where you might consider using serology. An antibody test could be offered to owners as an alternative to revaccinating a dog for distemper, adenovirus, and parvovirus, and a cat for panleukopenia. However, when we talk about cats, this requires that monovalent panleukopenia vaccine because then you can vaccinate like a cat every 3 years against panleukopenia and every year, if needed, against calicin herpes virus. The problem is that we don't have these vaccines in all countries. So first, consider an animal that has been adopted from the streets and you have no idea of its vaccination history. How do you vaccinate it? While you could simply vaccinate the dog with core vaccines, it may be not necessary. So in this situation, conducting a serological test is an option. If the animal is seropositive, it's actually protected, and vaccination at that moment may not be required. Vaccination is an important and fundamental part of veterinary practice. However, in recent years, there has been a shift away from the concept that pets make a yearly visit to the veterinarian for a vaccine booster to what we call a preventive annual health check visit. Vaccination should be delivered as one part of this visit. Unfortunately, many clients believe that vaccination is the most important reason for annual veterinary visits, and many vets, especially in Latin America, keep vaccinating dogs every year, even with vaccines that protect for at least 3 years, such as canine distemper, adenovirus, parvovirus, as we said before. So during the annual health check visit, practitioners should evaluate the animal body score and nutrition. We should emphasize the importance of ecto and endoparasites control. Also, during this consultation, we can use point-of-care diagnostic tests for infectious diseases that are important in that area. It's important to address the necessity of dental care. And finally, during annual health checks, clinicians should assess the need for core and non-core vaccines for that particular year. This visit may still involve administering selected vaccines, which should be given annually, as the duration of immunity for these products is generally 1 year. However, an animal might not receive all core vaccines every year. Titer testing can be part of the annual health check visit to help decide whether a dog or a cat should be revaccinated this year. When the antibody titer is above the threshold, the infectious virus is neutralized, preventing it from entering the animal cells to replicate. This concept becomes evident when maternally derived antibodies neutralize a modified live virus vaccine. So administering a booster of modified live virus vaccine to an already actively immune dog or cat offers no benefit in the presence of sterilizing immunity. In this situation, administering more doses of vaccine does not induce higher titers. So if a dog is seropositive for distemper, parvo, and adenovirus, it is still protected and it doesn't need that core vaccine at that moment. There are owners that prefer to test their pets than giving a vaccine. In this case, we recommend to perform serology annually in older dogs and cats, and not just every 3 years. Another situation to use serology is when you need to vaccinate an animal that had suffered the previous vaccine-associated adverse event. The need for revaccination should be carefully evaluated. So for distemper, adenovirus, parvovirus, and panleukopenia, this decision can be made based on the results of serology. This schnauzer here is Maggie, that had a type 1 hypersensitive reaction when she was vaccinated at 6 years of age. And this other dog is Luna, a German Spitz, who developed an immune-mediated thrombocytopenia 2 weeks after the core vaccination when she was 4 years old. We are quite sure that the vaccine may have triggered the immune-mediated disease. Maggie never received the vaccine again and was seropositive for distemper, adenovirus, and parvovirus until she was 14 years old when she died. And Luna is still seropositive for the 3 components after more than 7 years. Another situation in which the requirement for vaccination can be determined by antibody measurement is in immunocompromised cats. In this review, the European Advisory Board on Cat Diseases, ABCD, discussed the vaccination of immunocompromised cats. In addition to concerns about efficacy, there's a debate about the negative effects of vaccine-induced immunostimulation in FIV-infected cats, as immunostimulation could potentially lead to progression of FIV infection by altering the balance between the immune system and the virus. So their recommendation is that if adult FIV-infected cats that had been vaccinated previously are kept strictly indoors, the risk of being infected with other pathogens is likely lower than the possible harmful effect of vaccination. Ideally, antibody levels against panleukopenia should be determined, and vaccination should only be considered in cats lacking protective antibodies. If antibody measurement is not possible, booster vaccinations in adult indoor-only cats that have received previous vaccinations are not recommended. If potential exposure to panleukopenia, herpes, and calicivirus cannot be excluded, only core vaccines should be administered, preferably in an inactivated form. And what about FeLV-infected cats? Cats with progressive FeLV infection are more severely immunocompromised than those with FIV infection. Then, maintaining a good level of protection is very important. So vaccination against panleukopenia, herpes, and calicivirus should be performed regularly, even if the cat is kept strictly indoors. If the cat has outdoor access, we should vaccinate against rabies. Protection in an FeLV-infected cat after vaccination might not be as complete and long-lasting as in an uninfected cat. For that reason, either more frequent vaccinations or monitoring of panleukopenia antibody titers is recommended to ensure sufficient protection against feline panleukopenia. Another application of serology has been in the management of infectious disease outbreaks in shelters, specifically for distemper, parvovirus, and panleukopenia outbreaks. In the face of a disease outbreak, all animals currently resident within the shelter could be tested. Those who are seropositive are protected. This protected population should be separated from lower negative responder animals, which should be isolated and vaccinated. The susceptible population should not be adopted and should be kept in isolation until the incubation period of the disease has passed. The susceptible population might be retested after these intervals. The second population to be considered are animals wishing to enter the shelter in an outbreak situation. They should also be tested before considering admission. Seropositive animals may enter as they are protected from disease. Seronegative animals should be vaccinated and then ideally sent to foster homes and not allowed to enter the shelter until they have seroconverted when retested a few weeks later. Finally, in some countries, you cannot bring your dog to a boarding kennel or to a dog show unless it has been vaccinated with core vaccines every year. This is starting to change. As an example, the Danish Kennel Club accepts since 2017 a positive titer test for core components and at their events, and not just vaccination certificate as they used to do. So this is what I had to present tonight. Thank you all for joining me in this lecture, and I hope you found this information valuable. Thank you very much.
Thank you so much, Professor Marcondes. That was really, really interesting and really helpful. I can see on the chat that so many people were joining from around the world and really enjoyed it. And we've had some excellent questions come in. So I hope you're okay with me presenting them to you now.
Yes, of course, Jessica.
Fantastic. So our first question is testing antibodies in puppies and kittens a reliable way to determine when to begin vaccinating these patients for owners who want a more individualized vaccination protocol?
Okay, so thank you for the question. And the fact is that this practice doesn't make much sense when we think about the animal's well-being. It's complicated to take blood samples every 2 weeks, for instance, to check if an animal still has maternal antibodies. And another important point to remember is that depending on the vaccine, they can overcome the maternal antibody barrier before others. So sometimes, even in the presence of maternal antibodies, if they are low but still present, you can already have or elicit an immune response. So therefore, we do not recommend this conduct. The best option is to vaccinate every 3 to 4 weeks. And if until 16 weeks of age, it makes no sense to keep like taking blood samples to see when MDA has dropped. And another point is that we have different times that MDA drops. For instance, for distemper, parvo, adenovirus, they have different times, different moments where you can have an immune response. Sometimes a dog can respond to adenovirus before it responds to distemper and to parvo. So it makes no sense to keep doing this.
Great, thank you. That's a great answer. Our second question is, why is chlamydia in cat vaccines not considered core?
Okay, so this is a nice question also. Well, first of all, we have to remember that chlamydia vaccines do not entirely prevent infection and shedding of chlamydia after challenge. But the most important thing is that we don't have chlamydia in every single cat population. We see this only in multi-cat households where infection is confirmed. So just in this situation. And another thing is that we have seen more adverse reactions with chlamydia vaccines than with others. So we just use when we have a multi-cat household, when you have confirmed infection. In other situations, it's not an important vaccine.
Okay, great. Our third question is, how long after recovering from parvovirus can a dog be vaccinated?
Well, this is a question that I'm always asked in Brazil because we have so many cases here. And what we consider is that at least you have to wait at least 3 weeks after full recovery to start vaccinating again.
Okay, great. Next question is, it's a two-part question. It says, for cats, do you recommend vaccines only every 3 years against FPV, even if the vaccine is licensed for annual vaccinations? And do you recommend annual titer testing for this disease?
Okay, so the thing is, for panleukopenia, even if the vaccine is licensed with a 1-year duration of immunity, we know that if it's a live vaccine, a modified live vaccine, the immunity will be longer than this. And we have already many studies proving this. So there is no problem in vaccinating every 3 years for panleukopenia. But when you think of herpes and calicivirus, if those cats are at risk, if they have other cats with them in the same house, or if they go to catteries, or if and sometimes even in a clinic, sometimes you take your cat to a practice, and if it gets into contact with another infected cat, it can get infected. So in situations where you think that the cat can be exposed to calici and herpes virus, it is better to vaccinate every year. And I understand that, for instance, in Brazil, we don't have separate vaccines. In some countries, you have panleukopenia, a different vaccine from herpes and calici. So it's easier to deal with this situation. But when you have just one vaccine, sometimes you have no option, and then you have to vaccinate every single year. There was a second question. Sorry, I forgot about it.
Yeah, the second part was, do you recommend annual titer testing for this disease?
Yeah, we can just, as I explained in my presentation, we use just titer testing for panleukopenia, because this is where you have a correlation between antibodies and protection. So for herpes and calici, no, we don't recommend. But for panleukopenia, I wouldn't test every year. Sometimes some owners prefer not to vaccinate if they have the option. So I would test them every 3 years if this is available in your country.
Great, thank you. Our final question is, what are the potential risks if a puppy receives vaccinations before the recommended age?
You have two options here to possible adverse events. First of all, the puppy cannot, maybe his immune system is not prepared to respond, so you don't have a proper response to the vaccine because this puppy is too young or a kitten is too young. And there are some concerns when we use modified live virus vaccines, because those vaccines, those viruses, they infect, they don't cause disease in animals, but if this animal is, or this puppy or this kitten is too young, this can cause any harm. So, this can maybe cause disease. We don't know exactly how they will respond when you are giving a modified live virus vaccine. So we don't recommend to start before 4 weeks of age, when they start to respond properly.
Great. Thank you so much. That is all the time that we have for questions for today. As I said earlier, please don't worry if you did send in a question. It has been recorded. It will be presented to Professor Marcondes, who will provide answers. These will be sent along with the recording of today's webinar in around 10 days' time or so. So if you missed the start of the webinar, or if your question wasn't presented, don't worry, you will have access to all of it soon, and it will be sent to you, or it will be available on the Biogal YouTube page. Thank you so much, Professor Marcondes. That was really, really helpful, really fascinating, and we all really appreciate your time and expertise in this. I'd like to also thank Biogal for putting on today's webinar. Thank you to all of our translators for their live interpretation of the webinar. And thank you to everyone that has joined. It was great to have you all taking part. Please do keep your eyes out for future webinars and future information coming out. We will be in touch soon with all of that. Before then, if you would like any more information, please go to www.biogal.com to find out more. Thank you again, and we hope to see you all again soon. Bye-bye for now.
Thank you, Jessica.